Bismillahirrahmanirrahim. I have a short presentation about two cases of hypermobile Wrisberg type Doscoid lateral meniscus. Short description of the anatomy of the lateral meniscus. The lateral meniscus normally cover less than 80% of the surface of the tibia. It's attached to the tibial surface with the anterior horn and posterior horn, which are located around the insertion of the ACL on the tibia. Then there's the coronary ligament or the meniscotibial ligaments, which attach the meniscus to the tibia. They are deficient in the area of the popliteus tendon, and at this area they are thickened, making the popliteomeniscal fascicles, or called the furnicula. And then there are two ligaments posteriorly attaching the posterior horn of the meniscus to the femoral condyle. One anterior to the PCL is ligament of Humphrey, and the one posterior is the ligament of Wrisberg. And there's recently some reports about the presence of meniscofibular ligament. Doscoid lateral meniscus is a common some findings, but it is affect about 15% of the Asian populations and 5% of the Western populations. It's bilateral in 50% and equally presented in males and females, and there's strong familial tendency. It's classified according to F.Abd classification to three types. Type 1 is complete discoid, which is the meniscus is disc-shaped, covering the whole meniscus, the whole tibial plateau, but it is stable because the ligaments or attachment are intact. Type 2 is covering more than 80%, but it is less than 100%, and it still is stable because it's covering the meniscotibial ligaments, and the horns are intact. Type 3 is either normal shaped or discoid shaped, but the characteristic of it is lacking the posterior horn and is attached only using the meniscofemoral ligament or the Wrisberg ligament to the femoral condyle, and it is usually hypermobile. Type 3 Wrisberg is sometimes difficult to diagnose, especially if the meniscus is normal shaped, and if it's treated with socialization, it may be, it is always unsatisfactory for the patient, so you have to adapt your eye to see it. I present this case with, that's how it appears, as we see here in the MRI. We see the the absent posterior horn of the lateral meniscus. You can see it in comparison with the medial horn, and you see the hypertrophic meniscofemoral ligaments. I present this case as a 13 years old male. He suffered a sport trauma during a sport lecture in the school, and since this is 1 year ago, he was not able to attend the sports lesson and went to several doctors. They say that he's normal, and he was accused by his teachers to being malingering because he is not willing to attend the sports lessons. I saw the MRI. If you have the first look, you think this looks normal MRI, and everyone didn't comment any abnormalities. But clinically, he have all signs of positive that suggest a lateral meniscus injury, clicking, pain, joint line, and positive McMurray test. If you look at the cuts of his MRI, you can see the absent posterior horn of the lateral meniscus compared with the medial side, and you see the hypertrophic meniscofemoral ligament. And if you look in details, you see that the meniscotibial ligaments are attached and starting to make a small cyst laterally. That's how I treated. I went arthroscopically. As you see, there's posterior horn is completely missing, and the meniscotibial ligaments are insufficient. That's making the meniscus hypermobile and unstable. So I placed two certain fiber tapes using the meniscus scorpion. Then I use the ACL guide to put a guide wire. Just guide wire. He's 13 years old, so I didn't want to have injury of the growth plate. And I pulled the sutures inside. Here you see how it is being stable just with pulling the sutures. Sutures are then tied over an end button. Because the unstable or the insufficient meniscotibial ligament, I placed also two all inside sutures to stabilize the meniscus posterior to the popliteus tendon. The father of him sent me this video. He's now 3 months here, 3 months post-operative. He can finally, he's lacking last degrees of flexion. He finally, after 1 year, is able to ride his bicycle, and he's very happy. And we are working on the last degrees of flexion. So another case I operated just last week. He's a male patient, 16 years old. He had a partial meniscectomy in another clinic 1 year ago. And since the operation, he's unhappy. He's still having clicking, catching, and painful knee. And again, all signs for lateral meniscus are positive. As you see, the meniscus was socialized, but you may say it's not completely socialized. But if you look thoroughly again, you see here the absent, almost absent posterior horn, the hypertrophic meniscofemoral ligament, and the insufficient meniscotibial ligaments. Here again, intraoperatively, I went inside. You see the meniscus is lacking the posterior horn. It's well socialized. You see the previous surgeries seen in the meniscus, but the posterior horn is hypermobile. I fashioned the insertion of the horn. I placed the two fiber tapes again with the meniscus scorpion, and now you can see I am having the control. And when you position, you see that the meniscus is not fully trimmed as we saw in MRI. Again, using the ACL guide, I placed a guide wire, pull out sutures. I pulled these sutures inside the tunnel, and again I fix it after completing the trimming of the meniscus. I fix it as with all inside sutures, and now you can see the posterior horn is stable, and you see that the meniscus is now socialized as it have to be. Thank you very much.